Right. Hello, everybody. I'm Dr. Yadva, one of the stroke consultants in Birmingham Heartland Hospital. And Dr. Thakur has invited me to give you a talk on stroke. In my plan, I've got 3 cases to stimulate your brains that give you a kickstart. I'll run the cases with you and see what you make of them. I'll try to make it interactive, but yes, we are limited through the audio, but if I could have your answers through the text messages, that would be good. So I'll start with the case number 1. So this is a 64-year-old man who was brought in by the ambulance after being found confused in the town center at around 4 o'clock in the evening. And you are one of the residents who are seeing him in the emergency department. And you come across the patient at 5 o'clock in the evening. You find him lying in the couch, drowsy but arousable. He's not verbalizing coherently. And his GCS is E3V2M5, which makes it 8 out of 15. You notice a mild right facial droop. And you score his NIHSS score as 9. Does everybody know what NIHSS score means? Those of you who don't know, it's a National Institute for Health stroke scale, which is the single stroke scale, which is used by the stroke clinicians to measure the neurological deficit. They measure it on the 15 points, and the score ranges from 0 to 41. Anyways, what would you do when you come across this patient? Any answers? You can text me on the chat. Okay. So blood sugar, CT head, anything else you want to know? Okay, it says airways patent, breathing is fine, air entry is equal, blood pressure is 175 by 106, and his blood sugar is 2.4, and that's a CT scan. What would you do next? You can type your message in the chat box. So you got his CT scan, his blood pressure is high, his air entry is equal, he's saturating well, and his blood sugar is 2.4 millimole per liter. What would you do next? Excellent. So as you give him glucose infusion, his blood sugar comes back and his GCS starts to get better. His GCS improves to 13 by 15. He starts talking coherently, and his right facial droop also disappears. So this was a classic case of a patient who is presenting in the ED with low GCS with mild lateralizing neurology, but elephant in the room is his low blood sugars. And as you correct his blood sugar, his neurology disappears. So stroke mimics are common in the emergency department, and we must not forget the basics of day-to-day care, checking their blood pressure, checking their blood sugar, making sure that the oxygen saturations are okay. So the stroke happens as a sudden event, 8 out of 10. It's a cross-sectional event. You are fine at one moment and you're not fine at the next moment. Majority of the stroke symptoms are negative or loss of function. The explanation for the lateralizing sign, essentially the hypoglycemia can give you focal seizures. It can give you a mild neurological deficit in relation to the ictal activity of the brain. So as a result of the hypoglycemia, you do come across often a transient neurology. Often it is an after effect of cerebral hyperirritability from the hypoglycemia. And as you correct the hypoglycemia, that neurological presentation resolves very swiftly. If patient had remained prolonged hypoglycemia, then you may come across irreversible brain damage where you will come across patients who continue to remain in low GCS and make a very slow recovery whatsoever. And some of them end up having irreversible cerebral dysfunction. So coming back onto what are the hallmarks of stroke presentation. So it's a cross-sectional event. You find one moment and next moment you're not fine. You get in a lateralizing neurology. Positive symptoms are uncommon in stroke. So presentation as a pain in one of the limbs, pain in the chest, or involuntary movements indicate a non-stroke pathology. Stroke, by definition, doesn't cause loss of consciousness, although bearing in mind in the posterior circulation strokes, for example, if your midbrain is involved, then you will come across patients with impaired consciousness levels. But by the time they're having impaired consciousness level, they will also have significant neurological deficit in terms of tetraparesis. You will come across some ophthalmoplegia along with the impaired consciousness. And as I mentioned in the case we started with, always check their capillary blood glucose and blood pressure. So on that note, we've got a second case. It's a 46-year-old man who is brought in by the ambulance after being found confused in the town center, again at 4 o'clock, and you see him in the emergency department at 5 o'clock in the evening. Very similar to the earlier man, he's lying in the couch, drowsy but arousable, not verbalizing coherently. GCS is 8/15, and his NHS score is 9, and he's got a right facial droop. Again, what would you do? Same things, A to E. I'll check his blood pressure, that's fine, 150/90. His blood sugar is 7.4 millimole per liter. And I agree, you will do an urgent CT brain scan. And he gets a CT brain scan. And any volunteers, what you can see in the scan? Okay. Point taken, Sakar. What is different on the left side? Yeah, excellent. So left MCA thrombus. He's come within the hour of the presentation. What are you going to do next? You've got his NHS score, you've got his initial parameters. Excellent. So I think right thing at your level would be to contact your stroke team. Yes, I agree, patient is a suitable candidate for thrombolysis and thrombectomy. We quickly skim through their past medical history. Often, if the patients are out of area of your hospital, then you may not get all the information, but we try to speak to the next of kin if they're available. I often use patient's own mobile to contact the person whom they contacted last. So if you're not working in a thrombolysis center, then you ought to arrange an urgent transfer to the nearest stroke lysis center. As soon as you've spoken with your stroke on-call team, they will take over the patient from you and they will appreciate your initial assessment. He is in thrombolysis period, so he will get urgent IV TPA, which is 0.9 milligram per kilogram body weight. You give 10% as bolus, and the rest of it goes in infusion for 60 minutes. Because he's got an MCA thrombus, he's also a candidate for thrombectomy, so he should also get a CT angiogram as soon as we can, and that will allow the interventional neuroradiology to do a thrombectomy. Given the size of the hyperdensity in the scan, it's likely that thrombus burden on the left middle cerebral artery is large. It will be around 1 centimeter long thrombus to take out. When thrombus burden is high, then we now know that systemic thrombolysis doesn't work as effectively as we would have hoped for. So he will be best served with thrombolysis at the start and then going ahead with the thrombectomy. On that note, the third case for you. This is a 54-year-old man who's been found collapsed in the toilet at 4 o'clock again, and you're seeing him in the emergency department at 5 minutes past 5 in the evening. Again, he's lying in the couch, drowsy but arousable, not verbalizing coherently. He's snoring. His GCS this time is E2, V2, and M2. He's weak in all his 4 limbs. He's got a right facial droop. His NIHS score is 20. What would you do again? Okay, good, Lauren. A to E assessment. Because he's snoring, you have a very valid point that you're worried about his airways. Yes, you got them down. He's got a low GCS and high NIHS score. So the anesthetic team have come down. They have secured the airway. They have put an eye gel for him. He's tolerating the eye gel. What next? Okay. He didn't mention that you will check his blood sugar. So again, even with this presentation, you still ought to do their basics. So blood sugar needs to be checked in addition to A to E assessment. Thankfully, blood sugar for this patient was 12.4. So he had a CT scan. And what do you see in the CT scan? Anybody? Yeah, there isn't an infarct. Yes, you can see some shadowing through the bones. But can you appreciate the hyperdense basilar artery? Normally, it won't be this wide. The appearance would be more like this. Yes. So he does have basilar artery thrombus leading to a brainstem ischemia. So he had an urgent angiogram. And as you can see that this is the basilar artery, and that is a superior cerebellar artery coming out of it. And towards the tip of the basilar artery, there is a paucity of the contrast. There's a long thrombus at the distal segment of the basilar artery. And that's causing the problem with the brainstem and pons ischemia. Does anybody know what are the branches of basilar artery? I'll show you in my coming slides, but essentially basilar artery is formed by the union of two vertebral arteries. And then as it traverses through the medulla and pons, it gives lenticular striate branches to the pons and midbrain. And its branches include anterior inferior cerebellar artery, superior cerebellar artery, and posterior cerebellar artery. So this patient, again, was seen very quickly from the onset. So he was given systemic thrombolysis, and then he was taken up for thrombectomy, and a large thrombus was sucked out of his basilar artery. He remained in ITU for a day, and then 48 hours later, he walked out of the hyperacute stroke unit without a residual neurological deficit. So when you are doing the front door medicine, I just want to take you through the basics of what we expect you as a resident. That's a good question in the chat box. If someone has low consciousness, how would you score, for example, their visual fields? If you can't score them, then you don't give them a mark. So say they have a low consciousness, then you will be scoring them for bilateral hemianopia, essentially blindness, if they're not able to look at you. Does that make sense? And that means their score will boost up to a higher level. Higher the score, more worse the patient is. So in acute stroke, when they arrive to us, our clock starts from the time when they were seen last well. Our clock doesn't start from when they were found unwell. So say somebody has been found with right-sided hemiparesis at 10 o'clock in the morning, but they were last well 6 o'clock in the evening before, then our clock starts from 6 o'clock. Say if we were to consider them for thrombolysis, we won't be able to offer thrombolysis straight away without going through the complex set of imaging, for example, doing the CT perfusion scans or asking for MRI perfusion scans to find out if there is any salvageable brain tissue there. So although he was noted to have hemiparesis on the right at 10 o'clock, but the duration of stroke from onset will be classed as from 6 o'clock in the evening before. So that's very important to find out when they were last well. Do try a level best to speak with somebody who had seen them before, who can give you a bit more insight into circumstances surrounding their stroke. Do a quick NIHSS score. As I said, it's 0 to 41 point scale, scoring on 15 items. Higher the score, more severe is the stroke. There's a beautiful website called as NIHSstrokescale.org, which is developed to train the clinicians in NIHS scoring. And once you've gone through its tutorial, it gives you a certificate, and hence you become a certified clinician in NIHS scoring. That has a relevance, especially for us who are doing our stroke research trials. It asks us to be certified, and at your level, I think it's a good skill set to have, easy to acquire, just needs going through all those 15-point scoring system, which I will show you in a minute. Always check their blood pressure, sugar, and temperature. These are the three things which will put patients at risk of developing a focal neurological deficit. So people in extremes of their blood pressure, in extremes of their sugars, and extremes of their temperature. I hope that makes sense. When they are coming in the hyperacute stage at the front door, they need a good green cannula to get an angiogram. If you put a blue cannula, then it won't tolerate the contrast flow, and you won't be able to get good CT angiogram images. All patients who are coming in the lysis period, they should have CT head and CT angiogram on arrival if we are considering lysis for them. Some patients may not be suitable, but that discrimination should be done right at the onset. You may find it difficult to exclude them, so you are expected to escalate the case to your seniors, preferably this on-call stroke team, which is available to you at the time. Any questions you want to ask? What about on waking? Yes, the wake-up strokes. So again, for the wake-up strokes, the onset clock starts when they went to bed last, or say if they woke up for the toilet at around 3 o'clock, then you know that they went to the toilet and they were fine. So you can reduce the time of onset from, say, for example, 3 a.m. in the morning. As long as there is reliable information that they walked to the toilet fine, not that they were staggering and falling around and crawled to the toilet. So that's the stroke scale I'm talking about. So it allows you to measure their level of consciousness. And allows you to give them 3 points based on what is their level of consciousness, 0 being fully alert, and 3 being comatose. Then it asks you to ask a couple of questions to assess their alertness state. So you ask them what's the month and what's their date of birth, and you score them accordingly. 0 if they answer both correctly, 2 if they couldn't answer either of it. And then you assess them whether they are following the verbal commands. So you ask them to open or close their eyes without giving them the clue by closing your own eyes. Make a fist and let it go. You give them the verbal command and see if they follow it. Then you assess them for ophthalmoplegia, see how they are moving their eyes. Are they following the movement of your eye or not? If they have a gaze palsy, then you will notice the eyes are deviated to one side. If it is a forced deviation, then even if you move their head left to right, the deviated eyes won't change the direction. Then you check their visual fields in each quadrant by giving a visual stimulus, for example, your moving finger. You check for facial paralysis, which is very commonly seen in our stroke patients. You ask them to show their teeth, raise their eyebrows, squeeze their eyes shut, and you score them accordingly. You check each limb for motor power. In stroke, we don't use MRC scales to check their power from 0 to 5. But we just ask them to lift their stretched arms and feet. If they're lying down, lifting it up to 45 degrees is fine. If they are sitting up, then lifting their arms up to 90 degrees is fine. And obviously the leg would be 45 degrees, no more. You check them for limb ataxia by finger nose test and heel down shin. You check for sensations through the pinprick. Touch is fine, but if you want to use a pinprick, that's equally good as well. Then you check their language, ask them to describe a picture on the paper. Your stroke nurses will usually have an A4 sheet printed out, which shows a boy and girl taking a cookie jar from the shelf, or a lady washing the vessel, and you score them depending on their capability to describe what's happening on the picture. Then you score them for dysarthria on mild, moderate, or if they are not able to say at all, then you score them mute. Then you look for extinction or inattention, wherein you give them bilateral visual stimulation by moving your hands in both left and right, and score them accordingly. I hope everybody is on page with the NHS scoring system. I've given you a link. You can go to that link and get some more information. It's good for you to get a certificate out of it, because it's a good skill to have when you're doing the front door. So that is the basic vascular anatomy for the brain supply. So you've got two arteries in the front, which is the two internal carotids. And then the two vertebral arteries in the back. And the four then enter into the cranium. So the internal carotid artery comes from the common carotid artery, and common carotid artery essentially at the around middle of the neck divides into external and internal carotid artery. The way we differentiate in imaging is external carotid artery gives a lot of branches in the neck, whilst internal carotid artery doesn't give any branch in the neck. So it's the first branch. As it enters the skull, it gives ophthalmic artery, which supplies the globe, and it has anterior choroidal artery and posterior communicating artery. And as it comes up in the skull, it enters the petrous canal and forms the middle cerebral artery and anterior cerebral artery. And the two anterior cerebral arteries are joined with each other through the anterior communicating arteries. So that's anterior circulation for you. And the posterior circulation, two vertebral arteries enter through the foramen magnum. And just as they enter into the foramen magnum, they give a branch to posterior inferior cerebral artery. And then they ascend into the cerebellum and join each other to form the basilar artery. And basilar artery then gives lenticulostriate arteries to the pons and the midbrain. And to the cerebellum, there is an anterior inferior cerebellar artery. And then higher up is superior cerebellar artery. And then it terminates into posterior cerebral arteries. And two posterior cerebral arteries then often are joined by the posterior communicating artery, which forms the circle of Willis. So it's important to know the vascular anatomy, because then it guides you which aspect of the stroke you're looking at, whether it's an anterior circulation stroke or the posterior circulation stroke. There's a brief glance, although the anterior and posterior circulation strokes are quite different presentations, but majority of your strokes in the emergency department are anterior circulation stroke. Around 20% of them are posterior circulation stroke. So the anterior cerebral artery supplies the medial frontal lobe, and classic presentation for anterior cerebral ischemia is patient coming with a isolated leg weakness. So say if you have left anterior cerebral artery circulation stroke, then patient will have right-sided weakness with right facial droop. Sometimes isolated right lower limb weakness can confuse people, and you may worry about lumbosacral spinal disorder, which is only fair. But if it comes out of the blue, where you don't have any back signs, especially if it comes in the context of cranial nerve weakness, for example, right facial weakness, then you ought to suspect anterior cerebral ischemic event. The left MCA supplies majority of the hemisphere, the frontal lobe, the temporal and parietal lobe, and the lateral aspect of the occipital lobe. So accordingly, you will see a crossed cerebral dysfunction. So left MCA stroke will give you the right-sided symptoms. The posterior cerebral artery supplies the medial occipital lobe and posteromedial temporal lobe, including the thalamus. And the hallmark of the posterior cerebral artery stroke is left, say if it is left PCA, the right homonymous hemianopia, and varying forms of motor sensory weakness, depending on how much of the thalamus and temporal lobe are involved. So as I was mentioning, stroke lysis, you can thrombolyze people up to 4.5 hours. 3 hours are the most important hours for people to lose their cerebral neurons. Majority of the people are eligible for thrombolysis when they present in first 3 hours. There's a bit of an equipoise between 3 to 4.5 hours, although we try to thrombolyze people up to 4.5 hours. But most people who get the benefit between 3 to 4.5 hours are the ones who are relatively well. The ones who have associated diabetes, who had previous stroke, or who are on systemic oral anticoagulation, they tend not to do as well if you thrombolyze them beyond 3 hours, even within 4.5 hours. The complication rates tend to be higher. So the stroke clinicians will choose those patients carefully for systemic thrombolysis. If they have a large vessel occlusion, then we'll prefer them having a primary mechanical thrombectomy in those situations. With a typical large vessel intracranial occlusion, it's a slogan we use, which is a fact that with every passing minute, you lose 1.9 million neurons and 14 billion synapses. So that's the scale of the loss. Time lost is brain lost. So sometimes your radiographers might say, oh, you just come within the hour, you got 3 hours to work on, but that's not true. The assumption that you got 3 hours to work on is fundamentally flawed. I think the clock starts ticking away as soon as they come across you, and you have to do the very best to get the right imaging and get the thrombolysis. National benchmark from door to thrombolysis is 30 minutes. It is quite a short period to get the assessment, get the IV access, and get the scan. But the wisdom behind putting that compressed 30 minutes time for you to act is that realization that the time lost is brain lost. So what are the qualifying criteria for stroke thrombectomy? So they will be accepted for mechanical thrombectomy if their NIHSS score is more than 5 and there's a visible large vessel occlusion identified in CT angiogram. You can't go for mechanical thrombectomy if you don't have a target to work on. So hence your interventionist relies on the CT angiogram. Once you've got CT angiogram and you can see a visible occlusion, then you can put the wire in and suck the clot out. What if the patient is not for thrombolysis? Well, you still have to give them the acute stroke care, which is if there's no contraindication to give them aspirin 300 milligram. You ought to assess their swallow before you give them oral aspirin, because often your stroke patients will have impaired swallow and they will be at risk of aspiration. So hence, if they have impaired swallow, you are gifted with a rectal preparation for aspirin. So you'll give them PR aspirin 300 milligram. And you within 24 hours, you should have an access to give aspirin. So say if they have impaired swallow, you should have an nasogastric tube and you use that to give them. You give the high dose of aspirin for 2 weeks and then change it to the clopidogrel. And give them atorvastatin 40 milligram, preferably a day after, because first day is quite critical day where quite a few of them will develop hemorrhagic transformation of the infarct. Yes, I had a prompt on antihypertensive. Tolerate higher blood pressures, especially if they have a large vessel occlusion, then often there is a cerebral autoregulation and brain would need slightly higher blood pressures to maintain the perfusion. So we don't try to lower down the stroke outside the thrombolysis window if their blood pressures are high, unless they're having secondary target organ damage. Yes, if blood pressure is more than 185 millimeters of mercury, then we try to bring it down to less than 185. For stroke thrombolysis, your blood pressure has to be less than 185 by 100, and you use labetalol or GTN infusion to bring it down to achieve that. If they were not in lysis, they won't be considered for CT angiogram. So you will get a carotid Doppler instead, which has less radiation to give to patient. And you'll arrange an ambulatory ECG, preferably a 72-hour ambulatory ECG to screen them for PAF. I'm running short of time, but I'll run through this case quickly with you. A 66-year-old man who collapsed at home with right-sided weakness and headache. You saw him an hour later, and he was noted to have an IHS of 8 with right hemiparesis and dysarthria. His blood pressure was 194 by 104. He's on dabigatran 150 milligram twice a day for his AF. What would you do? Yep, understandably, you will go for a CT scan, which shows a right cerebellar hemorrhage. Anybody can text me, what would be your action plan for this patient? Yep, you will give Praxpine, stat dose. What else? You will be contacting your neurosurgical colleagues on call. Remember, it's a right cerebellar hemorrhage, so chances of developing rising intracranial tension are quite high, especially in the posterior fossa, because it has got less space to accommodate rising cerebral edema, which will happen by default in the coming hours. And yes, you're right, his blood pressure on arrival is 194 by 104. So you're meant to bring their blood pressure down to 140 mmHg systolic. Doesn't matter which agent you use, often easily available are IV labetalol or GTN infusion. Labetalol is preferred, but if there's a contraindication for labetalol, you can use GTN infusion. You'll watch for their neurological deterioration. They will be needing a close neuro observation for the first 24 hours. He's 66, so I would expect my neurosurgical colleagues to keep a low threshold to transfer him over to their neurosurgical unit because he's likely to deteriorate in the next few hours. If it was a cortical bleed rather than a cerebellar bleed, then they are at high risk of seizures, so we'll monitor them for seizures as well. If the GCS drops in the ensuing neuro observations, then this is a differential you've got to remember. So A, worsening bleed, so they will need a repeat CT. There will be worsening edema, they will be at risk of hydrocephalus. And as I said, if there is a lobar or cortical bleed, they're at high risk of seizures, and they will be prone to develop chest sepsis through the aspiration of their own saliva. So please bear these things in the mind. Not last but not the least, what would you do if it was a TIA? So by definition, the NHS should be 0. You can't have NHS 1 or 2, and you can't call them a TIA in that case. So you'll have to call them minor ischemic stroke, which will need a confirmation through the urgent brain imaging. So again, if you think clinically it's a TIA, you will be speaking with your on-call stroke team, and you will give them aspirin 300 milligram stat and ask them to take once a day till they get seen by your TIA clinic, who should be aspiring to see them within the 24 hours of receiving the referral. All anterior circulation TIAs, if suitable for carotid endarterectomy, will need an urgent carotid Doppler study. Routine bloods, including ESR, CRP, lipid profile, and HbA1c. All of them, if they are suspected to have a ischemic event, should be screened for paroxysmal AF. The ones who are not moribund, they should have an echocardiogram. For young patients, the neurovascular teams will be considering thrombophilia and vasculitic screen as well. So I realized that, I haven't got much more time. So over to Ashish, unless anybody has questions. So it is 300 milligram once a day, Anna. We use higher dose just to overcome any aspirin resistance, if any, whilst we're establishing the diagnosis. Once they have been seen in the TIA clinic, we would choose an option of converting aspirin to cloprazole 75 milligram OD. We also, in selected patients, choose the option of dual antiplatelets for first 3 weeks, but that will be down to the neurovascular team. Is that the bleed one you want to look at? Okay. Anybody else? It's a 300 PR.
Hello. So I'll share my screen. So hello to everyone. I'm starting. My name is Sabyasachi Mitra. I'm one of the doctors in Pinderfields, and I'm supposed to give a presentation on case-based discussion. So I will be starting with it. So the presentation of the patient was that it was a 40-year-old female who came to the emergency after a sudden collapse at the market about an hour back. The patient was confused and looked dehydrated. GCS was 14 by 15, E4, V4, M6. Airway was patent, breathing was fine. The blood pressure was a bit low, 84 by 60, heart rate 96, temperature of 35.6, and respiratory rate 20. BM was found to be 4.5. The patient was not able to give proper history, but on examination, we could find that there was a bit of tenderness in the abdomen. And the ambulance crew told us that the patient was vomiting on the way to the hospital, but denied any seizure-like movements and incontinence. And the patient was aparaxial. So at this point, what does it look like? What would be the first working diagnosis? An acute abdomen, sepsis, or something else? If people could type in. Okay. Okay. At this point, I would say sepsis wouldn't be a bad diagnosis to work on. Going by that, the patient has presented with confusion, low blood pressure, and collapse. So probably we could start with treating sepsis, but we might require a bit of the background and our viewpoint might change. Yes, I agree. That's a question. That's a valid question. What makes people think it's C? Rather, I would say sepsis would be a better diagnosis at this point. More rather a safer diagnosis at this point. Yes, we do not have a history of that yet, but we need to rule that out as well. Probably differential blood pressures at different limbs. Okay, that's part of acute abdomen really, ovarian torsion, ruptured ectopic, part of acute abdomen. Okay, so we'll move on. So more details, she is unable to give further history, but GP notes suggest that she was generally fit and well till last 6 months. In the last 6 months, she complained of worsening lethargy, weakness, dizzy, anorexia, and recurrent vomiting, losing appetite and losing weight, about 6 kgs in 3 months. Moreover, on her last visit to the GP, her BP was recorded as 96 by 68 in lying and 74 by 54 in standing. Advised to eat and drink more, probably diagnosed as orthostatic hypertension. Tests were done, others were unremarkable. Only TSH was a bit high, around 15.76. Diagnosed with hypothyroidism and started on levothyroxine. It was dispensed 2 days back. The patient is unable to clearly state whether she took the tablets, but nods yes on asking. At this point, it doesn't look like an acute event anymore. it looks like an acute exacerbation of a chronic event rather, which was happening over the last 6 months. So now, what is the best way to manage this patient? Oral levothyroxine, IV levothyroxine, IV fluids, oral steroids, IV hydrocortisone, IV antibiotics in the line of sepsis still. So you can put in your answers in the chat box. Okay, so I can see one answer, E. Yes, more is coming in. Yeah, E, I agree with it. IV hydrocortisone. Okay, so IV hydrocortisone and oral steroids, fluids, fludrocortisone, IV antibiotics. So in acute management, what else do we believe we have to give this patient to? So I agree with it. Fluids, yes, we have to give fluids, and probably it will be better if we give normal saline and dextrose in alternate bottles, because our BM was low as well, which is probably due to the Addisonian crisis as well. So fluids, and so yeah, fluid combinations would be normal saline and dextrose in alternate bottles. And yes, in the long term, we will move on to oral steroids and fludrocortisone, but in acute management, fludrocortisone is not required because high dose IV hydrocortisone has mineralocorticoid effects. And yes, IV antibiotics would be reasonable as well, because we have to rule out whether any infection has really caused this acute crisis situation. So yes, IV antibiotics are a reasonable choice as well. So acute management with fluids and IV antibiotics, and then long-term management with oral steroids and fludrocortisone. Yes, so all of them were correct answers, just we have to find the correct order. Okay. So triggers of Addisonian crisis, as we said, infection, yes, good to treat the infection, vomiting, diarrhea, dehydration, major stress like operation, accidents, trauma. So along with this, from this case, actually we learned, and it is known to cause that correcting thyroid hypothyroidism with levothyroxine can become a trigger for Addisonian crisis if it's actually from Addison's disease, because Addison's disease sometimes can cause high TSH as well, can be coexistent with hypothyroidism or Hashimoto's thyroiditis or autoimmune thyroiditis. So it can coexist, and it can be a wrong high TSH as well, false high TSH as well. So yes, correcting TSH can cause Addisonian crisis as well. So immediate management, we agree with that. Hydrocortisone, normal saline, and correct blood glucose. So what are the features of Addisonian crisis? As you could see, it was shock, low blood pressure, confusion, reduced level of consciousness, abdominal pain, mimicking acute abdomen, nausea, vomiting. The biochemical abnormalities are low sodium, high potassium, and low glucose. So we move on to a bit of anatomy, a bit of basics. The adrenal cortex. So the adrenal is a suprarenal gland. As we know, is a small gland situated just on top of the kidneys, both of the kidneys. And it has two parts, adrenal cortex and adrenal medulla. We are more concerned about the cortex right now. It has three parts again, three zones, glomerulus, fascicularis, reticularis, creating three different hormones, mineralocorticoids, glucocorticoids, and androgens, as you can see. So all three necessary for life. And adrenal medulla, just a short note of it, that it creates the other three very, very important hormones, adrenaline, noradrenaline, and dopamine. Okay, so we go ahead. So the hypothalamus pituitary adrenal axis, everyone knows about it. It's the hypothalamus creates the corticotrophin, then the pituitary creates, on its stimulus creates the ACTH, and the ACTH stimulates the creation of cortisol. So the renin-angiotensin aldosterone axis, so renin cleaves the angiotensinogen into angiotensin 1. The stimulation for renin to release is usually renal artery hypotension and low sodiums. So it cleaves angiotensinogen to angiotensin 1. And then angiotensin 1 is converted to angiotensin 2 with angiotensin converting enzymes. And so that causes increased blood pressure, increased sodium retention, increased vasoconstriction, and release of aldosterone. So aldosterone on its turn increases sodium, increases water retention in our body from the kidneys, but it releases potassium in its turn. So we lose potassium, but gain sodium and gain water and gain chloride as well. So you can understand deficiency of aldosterone can cause the exact opposite. So it will be high potassium and low sodium because of deficiency. So types of adrenal insufficiency are primary, secondary, and tertiary. So primary is from the gland itself. So the gland can be destroyed or malfunction. So the missing hormones will be all three, cortisol, aldosterone, and the androgens. The secondary is usually from the problem with the axis, probably due to ACTH production deficiency, probably from the pituitary. So if the pituitary is destroyed or malfunctions, so because it causes less stimulation on the adrenal, we have the missing hormones like cortisol and androgens. And tertiary is because of excessive use of steroids, which can suppress the ACTH, because when there is enough steroids in our body, the pituitary does not require ACTH to be produced. And so a long-term steroid use can lead to a long-term low ACTH and lead to a long-term low cortisol in our body from the adrenal gland, because the steroids are getting replaced from outside. So these are the Addison's disease and Addisonian crisis, how it can present, the clinical presentations. So you can see that in the chronic disease, it would be like dehydration, nausea, vomiting, abdominal pain, hyperpigmentation. So we'll discuss about that a little later. So postural hypotension, depression, psychosis, fatigue, weight loss. And in Addisonian crisis, it will just be a bit more that the patient will come with a shock or a hypotensive shock, pyrexia, abdominal pain, nausea, vomiting, confusion, coma. So this is a nice slide that I came across from courtesy from CaseBased Doses. So if you can see, it just summarizes what Addison's disease is with the name. So from A, you can understand there is ACTH excess. The most common type is the autoimmune destruction. There is abdominal pain, and we do the ACTH stimulation test, which is also known as short synaptin test. And as I said about the hyperpigmentation, we can remember it with the dark skin. So it's usually from the increased production of the melanocyte stimulating hormone, which is released alongside ACTH. So increased melanocyte stimulating hormone causes increased melanin and dark skin. And so we have salt craving, stress, orthostatic hypotension from O, and N, you can remember sodium low, and hypokalemia. So we move on. So yes, the causes, we know autoimmune disease is the most common cause, 80 to 90% in the Western world, and 40% would be in isolation. 60% will be part of autoimmune polyendocrine syndrome. So there'll be other organs affected as well, like the thyroid, like the celiac disease involved with it. So other causes would involve congenital adrenal hyperplasia and a few other genetic causes. Infections is very common, and it is the most common cause. Tuberculosis is the most common cause in developing countries, and HIV is also a very important cause. Meningococcus is known to cause a problem with Addison as well. And the other causes would include adrenal metastasis, amyloidosis, hematochromosis, and iatrogenic if the patient undergoes an adrenalectomy. So we'll move on. So investigations, we would prefer doing the serum or urine cortisol for the screening. We can do the plasma ICTH level, and the investigation of choice would be for the confirmation would be the short synaptin test. As we said, urea and electrolytes would be important, as low sodium and high potassium are usually involved with Addison's disease. Blood glucose may be borderline or low, and there can be liver and thyroid function test derangements, as well anemia, the increased liver enzymes as well, and mild or moderate hypercalcemia as well. So cortisol, we have to understand how we do the cortisol test and short synaptin test. So cortisol has a changing level over the day. So it's usually highest at the morning when we rise from bed. So serum cortisol should always be measured around 8 to 9 a.m. And so it reaches the zenith or the highest point at 8 a.m. and the lowest around midnight at 1 a.m. So if it's serum cortisol less than 100, we would think about adrenal insufficiency. 100 to 500 would be adrenal insufficiency is possible, and greater than 500 would be unlikely. But all of these values are if we do an 8 a.m. serum cortisol. If you do a random serum cortisol, these values might not match. But if it is at any random time, if it is less than 100, we can think of adrenal insufficiency. So short synaptin test, this test involves the IV administration of 250 microgram of tetracoxactide, which is the synthetic analog of ACTH. It can be administered IM as well, but IV is preferred. Cortisol is measured before the administration, 30 minutes after the administration, and sometimes can be measured 60 minutes after the administration. And it should be done in the morning because when the highest level of cortisol is already in the body. So if the rise is adequate from the baseline level of cortisol before administration, then we know the adrenal glands are working. So the problem is not with the adrenal glands. So plasma ACTH levels we can do as well if we want to know whether this is a primary adrenal insufficiency from the gland or whether it is secondary or tertiary due to the pituitary low ACTH level. So ACTH level can distinguish between primary and the other types of adrenal insufficiency. And so we can move on to management. Management, as I said, in the long term, Addison's disease is managed with hydrocortisone, usually with glucocorticoid replacement, and fludrocortisone for the mineralocorticoid replacement. And androgens can be replaced with dehydroepiandrosterone as well, but it is not usually done. And it is important for people to understand how Addison's disease and Addisonian crisis can be triggered. So whenever there is a chance of a trigger like an operation and an infection, injuries, so to prevent the crisis, they need to increase this corticosteroid cover. They probably need to double the corticosteroid cover. The fludrocortisone can remain the same, but the glucocorticoid needs to be doubled usually. And so the glucocorticoid replacement is usually divided in 2 or 3 doses over the day so that it can match the levels of glucocorticoid we have in the body. So the highest dose should be given in the morning, with half dose in the afternoon and probably half or quarter dose in the evening. So that's how it's divided, so that the normal level and range of corticosteroids can vary according to the diurnal variation. And glucocorticoid, along with that, we will replace the fludrocortisone as well, which is a fixed once daily dose around 500 to 1000 micrograms. So that's all. If you have any questions, you can ask me on the chat. So I don't see a lot of questions coming in. I think I have understood what I said. Sorry, Dr. Thakur, I can't hear you if you were saying something.